public health relevant articles in national journals. Most important, she is our board of studies member with whom we have every first MBBS, for first MBBS. I think we trouble her enough and more with our boards and our curriculum. Thank you so much, ma'am, for the contribution. Over to you, ma'am. I think you can just start off. Her topic is preventive strategies under tuberculosis elimination program. I think it's very, very important because with COVID and with so many other things, we've almost forgotten tuberculosis. But she's going to give us this thing on that. And for the panelists, we have Dr. G.S. Vijay Chandra, who is the Administrative Medical Officer, Institute of Thoracic Medicine. We have heard him before in the webinar. He has been our main speaker as well. And Dr. R. Uma Maheshwari from Madras Medical College, Community Medicine. Over to you, ma'am. You can start your introduction. We'll share your slides, ma'am. No, we can't hear you, ma'am. You have muted yourself.
Thank you very much for the beautiful introduction. And there was more love than facts in that. Thank you so much.
Thank you, ma'am.
And I would like to thank the Vice Chancellor, Madam, for having given me this opportunity. And I thank the chairpersons, Dr. Vijay Chandran and Dr. Uma Maheshwari, and all other participants of this webinar. So today, the topic for today is preventive strategies under National Tuberculosis Elimination Program. So, so all of us know that the program has been now renamed as the revised National Tuberculosis Control Program is now the National Tuberculosis Elimination Program. And we have a lot of changes. Like for the past 2 years itself, there's been enormous difference in the way we are implementing this program. And one very important strategy is the TPT, that is tuberculosis preventive therapy treatment, which has been introduced. So when we look at the burden of tuberculosis, India has the highest estimated burden of tuberculosis. Like we have about 35 to 40 crore Indian population having TB infection. What do I mean by TB infection? TB infection is a state of persistent immune response to stimulation by M. tuberculosis antigens with no evidence of manifest TB disease. So there is no gold standard test for testing this. And this is also known as latent tuberculosis. And from this pool of 35 to 40 crore, about 26 lakh are estimated to develop tuberculosis disease annually. So if we see that it's about 5 to 10% of those infected will develop TB disease over the course of their lives, usually within the first 2 years after initial infection. Next slide, please. The risk for tuberculosis after infection depends upon several factors. Ma'am, can we go to the next slide, please? Madam, next slide, please. Okay, the risk for TB disease after infection depends upon several factors. The most important is immunological status. And we see that the risk is increased to 25 times among contacts of bacteriologically confirmed tuberculosis patients compared to general population. And 16 to 21 times in case of HIV co-infection, and 3 to 4 times in case of other immunocompromised conditions like diabetes. 75% of people who develop tuberculosis disease after contact do so within the first year of diagnosis, and 97% within 2 years. So whereas if we see people living with HIV AIDS, the risk of developing disease is from 60% is up to 60% to 90%, and we can reduce this by we can reduce this development to disease among HIV patients by starting TPT. So it is estimated that tuberculosis preventive treatment alone can reduce the incidence of TB by 8.3% in Southeast Asian region. Now we have this national strategic plan for 2017 to 25, and it has a detect, treat, prevent, build approach. And if you look at the prevention aspect of it, prevention of TB disease by treatment of TB infection, that is, those who do not have the symptoms and signs and who do not have the active disease, they just have the infection where there is a response to the antigens, is a critical component of the National Strategic Plan for ending TB by 2025. Scaling up TPT would be the key to hasten the decline in rate of TB incidence. Right now, the decline rate of TB incidence annually, decline in rate is about 2.5%. We can scale this up to 10% if we scale up TPT. So the prevent component of NSP, that is the National Strategic Plan, there are three important aspects to it. One is the TB contact tracing and investigation, active screening for TB among the high-risk groups, and introduction of TPT. So if we look at the cascade of care approach for TB case detection, as well as for instituting the tuberculosis preventive therapy, the aim of cascade of care is to have significant impact on the individual's health, as well as to reduce the TB burden and transmission. In the cascade of care approach, we have to reach out to all all target population who are at risk of developing TB disease. They need to be screened for tuberculosis, and those who are found to be positive for active case should be treated as per protocol, and those who do not have active disease should be provided TPT, that is tuberculosis preventive therapy. So this is how the algorithm goes. I will tell you what the target population is in my subsequent slides. So for the target population, we'll have to rule out active tuberculosis by asking them if they have the 4 symptoms. And if they have, if we consider them to be presumptive TB, and lab diagnosis is instituted, and if it is confirmed, start TB treatment. If active TB is ruled out, then we have to test for TB infection and start TPT if they are positive for TB infection. Similarly, those who, for the target population for whom we have, we are ruling out tuberculosis, and we find that they don't have any signs and symptoms, then we have to evaluate for, test for TB infection as per policy, then evaluate for instituting tuberculosis preventive therapy and start TPT, and then do a systematic follow-up. All these I will be elaborating in my subsequent slides. So what should we expect? So far, whatever we have seen is for those patients with latent tuberculosis, or in other words, tuberculosis infection, as per the definition that I've been using from the start of my presentation. So for all these latent cases, there are about 100 patients, finally only less than 20% are able to complete the tuberculosis preventive therapy. There is a loss at every step. So though we intend screening 100%, we end up testing only 71 to 72%. And further, we lose more and more patients as we go through reference, if test positive, completed medical evaluation, accepting and starting treatment. In every step, we lose patients for follow-up, and patients drop out, and ultimately we end up completing tuberculosis preventive therapy for only less than 20%. Now, who are our target population for TPT? People living with HIV, excuse me, household contacts of tuberculosis positive, active tuberculosis patients. When I mean household contact, it is all those, it's just not family members, it's all those who share same enclosed living space as the index patient for 1 or more nights, or for extended daytime periods, any day 3 months before starting therapy. So we can understand that there'll be so many contacts for every single case of tuberculosis. So, so anybody who has stayed with them for even a single night, or share their common, space, the extra daytime for a single day also, in the last 3 months before starting treatment, they all become household contacts. So HIV patients, household contacts, and in third category is individuals who are on immunosuppressive therapy, having silicosis, or on anti-TNF treatment, tumor necrosis factor treatment, patients who are on dialysis, or patients who are being, waiting for an organ transplant or a hematological, transplant. So, what is the target population and what is the strategy that we have? Just a minute. Okay. So the target population for, I said 3 categories, right? One is people living with HIV/AIDS, the second is household contacts, and the third is the other group. So the first group, that is HIV, people living with HIV/AIDS, adults and children over 1 year. We'll have to start them on TPT to all of them after ruling out active disease. For infants less than 12 months, if they have a history of contact with an active TB case, then they have to be started TPT after ruling out active case. For household contacts, we have 2 categories. One is below 5 years and the one is above 5 years. So household contacts below 5 years, we definitely have to start them on, TPT. And for household contacts above 5 years, we have to do we can do a testing, TBI testing, that is the tuberculin skin test or any other test. And if they're found to be positive, after ruling out active disease, we can start TPT. For persons with a negative test, we don't have to do it. But we should not before treatment because X-ray test or TPT or tuberculin skin test was not done. That should not be a reason for deferring treatment. Okay, for the third group, that is individuals on immunosuppressive therapy, having silicosis, or on anti-TNF treatment, dialysis, and organ transplant, we have to do a TB testing. Okay, rule out active disease in them. Do it if they don't have active disease, then do a TB test, skin test, and if it is positive, start them on TPT. Again, I repeat, if the test is not available, skin test or IGRA, whatever is not available, that doesn't mean that we can delay treatment or defer treatment. We have to institute treatment in such cases. Okay, now again, a recap of whatever I have said, just to, reinforcement of whatever I said. So for people living with HIV/AIDS, we need to remember we are going to reduce the risk for TB by 50 to 90% among this category just by starting them on tuberculosis preventive therapy. So just we'll have that in mind and then proceed. So as I said, for anybody who is more than 1 year, we have to ask them for 4 symptoms. What are the 4 symptoms? Cough, fever, loss of weight, and night sweats. Currently, if they have any of these 4 symptoms, we have to do the TB diagnostic tests. If they're found to be an active case, start them on treatment as per protocol, NTEP guidelines. If it is negative, or those who are without symptoms, we have to start them on TPT. The degree of immunosuppression, or whether they are on ART, or if they have had TB treatment before, or in case of women, if they are pregnant, all these things are not contraindication for starting TPT, and we have to start TPT irrespective of all these considerations. Okay. And coming to infants less than 12 months of age who are in contact with the patient of pulmonary tuberculosis, we should start TPT. But we start them on INH for 6 months after ruling out active tuberculosis. But if there is no history of contact for an infant of PLHA infant, then there is no need for a TPT. Okay, so that is about the PLHS. Now coming to household contact of pulmonary TB patients. As I said, under 5 years of age, all household contacts after ruling out active tuberculosis without TBI testing. There is no need for TBI testing in under 5 children. We start them on PPT. On the other hand, for anybody who's over 5 years, we have to do a TBI testing. And of course, even if they're positive, rule out active tuberculosis. Say we can have a chest X-ray, rule out active tuberculosis and start them on. And if the testing comes out as positive, we have to start them on TPT. But if the lack of availability of a test, be it a skin test or an X-ray, does not, justify differing treatment. When I mean household contact, I reiterate, I also mean those who are in close contact with the pulmonary TB patient at workplace and other settings, regardless of their age. I hope I'm clear. Okay. For the third group, that is the other risk group, TB test, other risk groups, I already told you what is to be done. And this is another group like diabetes, malnutrition, smoking, and alcohol abuse, whom we know that there is an increased risk, but we do not give them TPT routinely. So, and we also have to remember there are some high TB transmission settings like in healthcare workers, inmates of prisons, mines, slums, tribal population, and migrant laborers. So they have to be mapped and active case finding is to be done. Though we know that they are high transmission settings, we don't put them under the TPT, but we understand that active case finding has to be done in them. And if cases are found, then the same protocol as for other groups should be followed. Okay. So long I have been talking about TBI diagnosis also. I said about skin tests. So let us look at what it is a little more in detail. So there are two tests mainly. One is the tuberculin skin test, that is our Mantoux, which we have all known for ages. And the other one is the interferon gamma release assay, IGRA. But let me tell you, there is no gold standard test for TBI. So these are tests which are available. Both TST and IGRA measure immune sensitization type 4 or delayed type 2 hypersensitivity. We have to remember that this is not a requirement for initiating TPT in HIV positives or children under 5 years in contact with ETB patients. Okay, now how do we diagnose diagnosis of TBI? As I said, these two tests, not only these two tests, we also have the ESAT-6 and the CFP-10, and in the commercially available quantiferon TB Gold assays, which are also available in many of these private labs, can also diagnose TB infection. But as I said, none of these is a gold. We don't have a gold standard as yet. So now coming to tuberculin skin testing or the Mantoux testing, which we all know, there are some, we have to have some implementation considerations, because so far we have not done it in a large way in our program. So for implementing this, we should ensure availability and supply, especially of PPD, because PPD has to be supplied, kept in cold chain. And the supply of syringes and other consumables should also be there. And training of health personnel in intradermal injection and interpretation of the results is also needed. And continuous ongoing capacity building and supportive supervision is also required. Quality assurance, again, that's an ongoing thing, and quality assurance has also to be done. And another challenge, and we have to ensure a mechanism for calling people within 48 to 72 hours for reading the test results. So that can be challenging, but we have to ensure a mechanism for that also. And once this is done, the results should be updated in the Prevent TB India app. So that's also required. Okay, now coming to IGRA, the implementation considerations in IGRA. First, we have to develop capacity of the laboratory system, and the technicians have to be trained. And we have to establish mechanisms to ensure rapid transportation of blood from the peripheral centers to the IGRA testing laboratory, which can see if we take PPD, it can be done, it's field friendly, whereas this, the blood has to be drawn and transported to the specific labs. And ensure functioning of lab equipment and establish a mechanism for regular maintenance. And we'll have to map out IGRA testing facilities, existing IGRA testing facilities, both in the government side as well as the private. We can collaborate with the private lab with the support of NHM. And once all this is done, updating the results in the Prevent TB India app should also be done. Okay, now comparing the TST and IGRA, we find that specificity for TST, that is the skin test, is low in BCG vaccinated individuals for obvious reasons. Whereas in IGRA, it is high even in BCG vaccinated individuals, specificity. Now coming to sensitivity, it is high for both the tests, TST as well as IGRA. Now coming to the use of ease of use, as I already mentioned, TST is field friendly, and of course the test interpretation can give, there are less than 5 millimeters, 5 to 10 millimeters, above 10 millimeters, each have different kind of interpretation, and the health worker should be able to do that. And IGRA requires lab and infrastructure, so there is no ease of use there. It requires a high-end lab for that. So coming to the cost of the test, TST is low, whereas IGRA is high. Manufacturing, it is an old product, complex old product, TST, whereas for IGRA, there are multiple components which have to be, are required. Actually, the test results interpretation can be affected by, can vary in children for TST and IGRA, both. So that is why we don't do it for children less than 5 years. And PLHI, for people living with HIV/AIDS, the tuberculin skin test interpretation, is a little complex. And similarly, for IGRA also, in PLHIVs, the test result can be affected by the viral, can be affected by the CD4 count. So since basically an immunological thing, the CD4 count is, can affect the test result. Again, I'm just going back, refreshing all what we have learned so far. It is just a simple algorithm that we all have to remember. There are 3 groups. One is HIV positive, that is PLHAs. The other thing is second thing is the household contacts of active TB cases. And the third is the other risk groups. When I say other risk groups, it's immunocompromised, people receiving drugs, or people having silicosis or TNF alpha treatment, all those individuals, they come in the third group. So coming to the first group, which is the HIV positive, we have to ask them for the 4 symptoms. Okay, the 4 symptoms are cough, fever, weight loss, and night sweats. If the answer is an S, then we have to investigate for active TB and rule out active TB. If it is active TB, start them on treatment. If it is not active TB, then we have to start them on preventive TPT. Okay. If the HIV positive patient does not have any of these symptoms, then they may be a candidate for TPT, unless the preventive treatment is contraindicated. I will tell you what are the contraindications little later. So if they have any contraindication, then we don't give them preventive treatment. But if there are no contraindications, we have to start them on TPT. Okay. So that is for HIV positives. Now coming to the second group, that is the household contacts. Again, we ask them for the 4 symptoms. So as again, I repeat, cough, fever, weight loss, and night sweats. If they have any of these, then we have to rule out active tuberculosis. If it is not active tuberculosis, start them on TPT. If it's active tuberculosis, start them on ATT as per the guidelines. Again, if they don't have symptoms, we have to see what is the age of the person. If it is less than 5 years, start them on tuberculosis preventive therapy. If it is over 5 years, you give the testing, either TST or IGRA. If the test result is positive, you start them on TPT. If the test result is negative, just leave them. All right. Again, if the test result is positive, here again, we have to rule out active tuberculosis because the test, the MAN2 is also maybe positive and the lesion can be there. So in MAN2 positive individuals, we have to rule out active tuberculosis even in them. And of course, in the third group, we have to do a testing for them. If the testing result is negative, leave them off. If the test result is positive, start them on PPT. One again, very important point I would like to say is lack of testing should not be the reason for deferring, in which case we have to start treatment. I hope I'm clear. Okay, now I said unless contraindicated, we have to start, right? So what are the contraindications? Absolute contraindication is active TB disease. So definitely we don't have to give them TPT. We have to start them on ATT as per. And the second condition is acute or chronic hepatitis. And then concurrent use of other hepatotoxic medications like such as nevirapine, especially in the PLHAs. So next, the contraindication is regular and heavy alcohol consumption. Then signs and symptoms of peripheral neuropathy already existing in the patient. Okay, not after starting, it is present already means we have to, it's a contraindication. And persons with known allergy or hypersensitivity to any of the drugs which we use in TB. So before starting TPT, the first very, very important thing is counseling. We'll have to counsel all the eligible persons because you can just imagine for every active case, there may be so many household contacts. And not only that, workplace contact also will be there. So by the time we start them, we should counsel them again because unless the person is, well aware of, what to expect. If they stop the treatment in between, we are having they start the TPT, stop the TPT in between. One is they become very prone for getting the tuberculosis, and the most important worrisome thing is they can get drug-resistant tuberculosis. So we have to ensure that the person understands the purpose and how we are going to do it and what to expect. What are the reaction. There's already a family member or a close contact having the disease, so he or she would understand it better. So counseling is very important. So once that is done, we have to do a pre-treatment assessment. So for pre-treatment assessment, of course, we have to check if they have any drug history and other things are important. Their health condition should be assessed. And we have to take a personal history of, and if regarding an allergy to drugs and HIV status. And if a person is HIV positive, then ART, if the patient is on ART regimen, what kind of regimen is it? All that we have to take into account. And if it is a woman, we have to find out whether she's pregnant or she is using any contraceptive. We have to take a history about the comorbidities and the medications that they take for these conditions. So all this should be done. And liver function test. Liver function test may not be done for everybody. That is not recommended. Only in patients whom they are known to have any problems affecting the liver, then we do an LFT. Otherwise, LFT is not routinely done. We also have to take into account the social and the financial situation of the patient. Because as I said, the social situation, if they're going to move out or what kind of it, will they be able to complete the TPT? We need to assess that also before we start the TPT. Okay, now what is the treatment that we are going to give? So there are two regimens mainly. Of course, there are some more also. but still some parts of the country have started implementing this. But in many areas, the TPT has still not become fully, implemented. So there are mainly two regimens. One is the 3 months of weekly rifampicin plus INH. So only it's once in a week for 3 months. It's just 12 doses of three. This is called as 3HP. So studies have have proven that the efficacy is similar to 6 months of daily isoniazid 6H, because we have enough experience with 6H, because that has been there for quite some time, even during the RNTCP time itself. So the efficacy of INH treatment for 6 months daily dose has already been proven. So the results with rifampicin plus INH for 3 months, once a week, is also as good as 6H. But the advantage is it has higher completion rate. The compliance is better with this regimen. And there is no high risk in pregnancy, like added risk because of this regimen is not seen in pregnant women. So coming to the next one, which is the 6 months of daily INH, which has been there for a long time. We all know it reduces the risk of TB incidence, in persons who are taking it by 33%. That's a proven one. The choice of regimen will be guided by the availability of the drugs and tolerability profile of the eligible people. Okay, this is again the going target population. It is PLHVs. I mean, we told this already, that the adults and children over 12 months, we start them, right? They can be offered either 6 months of daily INH or 3 months of weekly INH and rifampicin, 3HP. But when we give 3HP, it is for people who are older than 2 years only. For children less than 2 years, we don't advise this. The 6H is only the regimen of choice. Similarly, the same thing for household contacts below 5 years. We can give both, but as I said, less than 2 years, it is only INH monotherapy for 6 months. And for household contacts above 5 years, the same two regimens can be used. And children or adult on immunosuppressive therapy, silicosis, if they qualify for TPT, both the regimens can be, either of the regimens can be used. So if you look at the dose, 6 months of for the 6H, for individuals aged 10 years or older, the dose is 5 mg per kg per day. For children less than 10 years, it is 10 mg per kg per day. All right. So the range can be from 7 to 15. All right. The maximum dose of isoniazid that would be given daily will be 300 milligrams. So this is the age groups and the dose. So for INH and rifampicin, you can see the dose. INH and rifampicin, it's also available as a fixed dose combination with 150 milligrams of INH and 150 milligrams of rifampicin. So for a child weighing from 10 to 15 kg, that would be the combination will be 2 tablets, like that for different age groups is given there. So I think we will be well versed with this as we start implementing the different age brackets. We will be more familiar. So as we all know, INH is 300 milligrams, and for the different weight categories, it is like above 30 kg itself, it becomes 3 tablets of 100. All right. Now coming to peripheral neuropathy, the most common side effect to be expected. Peripheral neuropathy is secondary to deficiency of vitamin B6. It is commonly seen during TB treatment and infrequent with TPT because the dose is less, and so we don't see it so commonly with TPT. It is recognized as a symmetrical numbness and tingling of the extremities. It's usually reversible upon withdrawal of INH, and giving high dose of pyridoxine in therapeutic doses. That's about 100 to 200 milligrams per day. So it is a very much reversible condition. And we recommend pyridoxine prophylaxis when this person is subject to an INH-based regimen, if they are malnourished, if there is chronic alcohol dependence, HIV infection, renal failure, diabetes, or if the individual is pregnant or breastfeeding. The dose of pyridoxine for prophylaxis is 10 milligrams per day in children, 25 milligrams in adults, and 50 milligrams in case of P-electrics. So these are the common possible, I will say common, these are the possible adverse effects associated with TPT drugs. So for INH, elevation of liver enzymes, hepatitis, peripheral neuropathy, skin rash, and sleepiness. Rarely they can get convulsions, pellagra, arthralgia, anemia, and leukoid reactions. For rifampicin, gastrointestinal reaction, hypersensitivity, flu-like symptoms, hepatitis, and discoloration of body fluids. And rare events are hypotension, syncope, and decrease in white blood cell and the total count and RBC count, decreased appetite, and hyperbilirubinemia. So we need to remember these few points. Like in fact, there are many more adverse effects which I have not quoted, because these are the points I would like all of us to remember. The most adverse events are mild, self-resolving, and without sequelae. So once the drug is withdrawn, it goes out. A co-administration of commonly used ARVs with TPT regimens 6H and 3HP is safe, but some regimens containing nevirapine we'll have to, it is not to be given. Caution is required when an individual receiving TPT is also on treatment for comorbidity. So we have to look at the drug interactions before we start TPT. Rifamycins are potent enzyme inducers. So we need to remember that the drugs which are metabolized by the liver can be, can lose their, so higher doses may be required. So especially so in women with who are on hormonal contraceptives, because they are metabolized, the OCPs are metabolized fast, and she can't, have a contraceptive failure and get pregnant. So we have to think about other methods like barrier methods or IUCDs in such cases. Or if she's using an injectable, then we have to increase the frequency of the injections. Like if she's using a depot medroxy and progesterone acetate, instead of the usual 12 weeks, it can be given at 8 weeks, repeated. And similarly, implants also, they have to replace the implant a little more earlier. And liver functions are not done, tests are not done routinely, except if the patient has a prior history. Okay, now all of us have this question in our minds. We are starting off INH as a single drug or just 2 drugs. Will this not lead to emergence of drug resistance? Because drug resistance is something that all of us dread, especially in disease like tuberculosis. So let's see what the evidence has got to say. There is no evidence of significant association between development of resistance to either INH or rifampicin with use of these drugs for TB. Again, TB disease must be, the very important thing is the ruling out the disease. If a person has an active tuberculosis and we just put them on a single drug or just 2 drugs, then we will be causing drug resistance. So the most important thing before starting TPT is rule out active tuberculosis for 2 reasons. One is you are undertreating the patient, and the next thing is you are causing him to become drug resistant. So that is in our hands. Regular follow-up to rule out development of active. So once the patient is on TPT, also at every possible visit, we should be asking for the 4 symptoms. And even after that, it should be followed up for the next 2 years or so for the 4 symptoms, because the active disease can develop even when the patient is on TPT. Only thing is the chances are less, but it does not rule out active disease, development of active disease at all, totally. And rapid molecular drug sensitivity test, DST, must be offered to all patients if TB disease is detected before, during, or any time post TBT. So we should, as a routine itself, the NTEP has the DST, but we should ensure that it is done definitely for a patient who is on, for a person who is on TPT. Okay, now having all this in mind, there are some special situations where we have to consider about how we are going to do the TPT. One is women. As I already said, pregnancy is not a disqualification for a woman who is with HIV or without HIV for TPT. So if she is, if it's a PLHA or a non-PLHA, pregnancy is not a contraindication or disqualification for starting TPT. We can start it. Similarly, if TPT is started during antenatal period, then she can continue to continue. If she has to, the course has to continue through the postnatal period. She can do it. She should do it. INH and rifampicin are considered safe for use in pregnancy, and in LFT can be done as per advice of the treating physician, because in pregnancy we know it's pregnancy as such is a high. The liver enzymes can be raised in a few patients. So if that is left to the prerogative of the physician, treating physician, to do a routine LFT. But definitely pyridoxine supplementation should be given for all pregnant and breastfeeding women on TPT. There is limited data on the efficacy and safety of rifampicin in pregnancy. So that is, therefore 3HP usage in pregnancy is still not advisable. It is not available also. So for pregnant women, we still have the 6H regimen only. Then coming to contraception, as I already said, rifampicin and rifamycin and rifampicin both react with hormone contraceptive. They increase their metabolization, thereby the contraceptive efficacy decreases. So as I already mentioned, we have to change to another method or increase the dose. So coming to liver disease and TPT, persons who are with known liver disease on whom we have done a liver function test, if we find the enzyme values to be more than 3 times, we have to initiate with caution. But it is increased but less than 3 times only, then they can be started and followed up. If a person is suffering from end stage liver disease, then defer TPT. On the other hand, persons who are infected with hepatitis B or hepatitis C infection, 6H is well tolerated. Whereas if somebody is suffering from acute hepatitis, including acute viral hepatitis, we'll have to defer treatment, defer TPT till the acute phase is resolved. Rifamycins, including rifampicin, are not recommended for use together with direct acting ARVs, which are used to treat HCV, hepatitis C infections. Because again, the same problem, the drugs can reach subtherapeutic levels, so that the viral clearing doesn't happen effectively. The next special situation is patients with renal failure. We have to understand that isoniazid and rifampicin are eliminated by biliary excretion. So TPT can be given in standard dosages to individuals with renal failure. No problem. We don't have to decrease the dose for patients with renal failure, because the drug elimination is not through the kidneys. And persons with renal failure should definitely receive pyridoxine to prevent peripheral neuropathy. Okay, the next special category is babies born to mothers with TB disease or TPT. Either they receive TB treatment or with TPT. What is it? If the newborn is not well, then send him to a specialist pediatrician, a TB specialist or a pediatrician, and the treatment, the decision to treat is with them. But if the newborn is well, then TPT is provided. As we already said, in all through my slides, I've been saying all positive infant contacts of positive patients should be started on TPT. after ruling out active disease. So BCG vaccine, what do we do with the BCG vaccination? It should not be delayed. Even if the child is being administered TPT TPT drugs, BCG vaccination should be given. We also have to give pyridoxine for this child, for this baby, at a dose of 5 to 10 mg per day. If the infant is HIV exposed, we do not know the status. The mother is HIV infected and is on nevirapine, then we start on 6H. Naturally, for any infant, we start only on 6H. Because as I already mentioned, the 3 months of rifampicin and INH is given for children over 2 years only. Okay, then TPT with 4R and 3HP cannot be, these are 4R I did not discuss so far, cannot be given along with nevirapine prophylaxis since rifamycin decrease nevirapine levels and may result in increased mother-to-child transmission. So there, it's only the 6H we have to start. If the mother is taking anti-TB drugs, this is an often asked question. Can she breastfeed? Yes, she can breastfeed. She should breastfeed. Taking appropriate, cough etiquette. She should be using a mask. Thanks to COVID, all of us are with masks. It's easier to tell the mother, please continue wearing your mask when you're feeding the baby. And all the cough etiquette that we've been training for the past 2 years should be done by the mother also. Mother and baby should stay together, and the baby, as I said, the baby may be breastfed while on TPT. She should receive pyridoxine for the duration as long as the mother is on treatment. She should also be on pyridoxine, and the baby also. Next important category, high-risk category, is people who use drugs. So it is PWUD now. So people who use drugs have a higher prevalence of TB infection. And so naturally a higher incidence of TB disease also. So people taking 3HP or 4R, so they naturally, if they are on TPT, especially these 2 regimens, we have to, and if they are on therapy for the drug by opioid, usage, they should be monitored for opioid withdrawal, because the drug dosage, because of the metabolization, the opioid levels fall and withdrawal symptoms may occur. So 6H is safe to use among PWUDs after careful monitoring of liver enzymes. Liver toxicity is an important side effect here, and they're prone for it. Drug use should never be taken as a blanket rationale for denying somebody TPT. We should take these precautions, and then adjust the opioid dose if they are on therapy for withdrawal. Therapy for discontinuation, and give the TPT. It should not be denied just quoting this reason. Okay, I know it's a kind of there was a cognitive overload. I will not say it's a cognitive overload, but there was a lot of information overload, I think. Now coming to the last part, that is preventive treatment in drug-resistant tuberculosis. All of us have this question. We are all talking about rifampicin and INH only for TPT. But what if the patient already has drug-resistant tuberculosis? Yes, we have an answer. So for patients with MDR-TB, when I mean MDR, we understand they are resistant to both rifampicin and INH. There is a regimen with 6 months regimen with levofloxacin, 6-LFX. If the patient is sensitive to fluoroquinolones, we can give this treatment. Similarly, we have another regimen with 6H among contacts of INH susceptible but rifampicin resistant tuberculosis. Index patient. If the index patient is rifampicin resistant but sensitive to INH, we can start the contact on 6H. 4R can be given for contacts with known resistance with INH and rifampicin sensitivity. So the other thing, it's a converse of the previous category I said. So these patients are sensitive to rifampicin and resistant to INH. 4R can be used. We have to follow them for 2 years regardless of treatment, and any emergent signs and symptoms of tuberculosis should be actively investigated and regimen needs to be started. As per their, because they have to be subjected to drug sensitivity testing also. So this protocol, again, I'm not going to go into the details. It's similar to the protocol which I mentioned before, which I elaborated before. Only thing is we have to mandatorily test them for drug sensitivity. Though it is part of the NTEP already, but implementation changes may be there, or some places it may not be implemented as we think. But we have to ensure in such cases, that is contacts of drug-resistant tuberculosis patients, they have to have if they are found positive, then they have to have a drug sensitivity testing. Otherwise, it is similar. So this is again, the TPT regimen for contact with the, I already mentioned it. 6 months of daily levofloxacin for contacts of MDR-TB sensitive to fluoroquinolones. And 4 months of rifampicin daily, 4R for contacts of H resistant and R sensitive patients, and 6 months of INH alone for H sensitive and R resistant patients. Thank you, all of you, and thank you, chairpersons, for allowing me to present. And thank you once again, Vice Chancellor Madam, and the university for having organized this and given me this opportunity. Thank you.
Thank you so much, ma'am, for that extensive slides that you showed us, and your presentation was so good. Actually, we could have listened to quite more of it, maybe if we had a little more time. Actually, there were just 2 questions, but before I go to mine, I'd like Dr. Vijay Chandran sir to tell us a few things. You want to comment, or how does it go? So you can just pull in your views.
Yeah, thank you, madam. And thanks, VC madam, for inviting me as a chairperson. And that's a nice one from Dr. Priya. It was almost like a UG class lecture rather than a webinar. She summarized every now and then what she said. That was a nice one. And regarding our topic today, tuberculosis prevention is very close to my heart, not because I'm a pulmonologist, but this is one disease which we have not conquered. Mankind has not been able to conquer over many centuries. Because the earliest evidence of tuberculosis was found even in Egyptian mummies. So from then on, we are still not able to conquer the disease. But I have a different take for prevention. Tuberculosis is a socio-economic disease. It is just not a medical disease. Okay, so if it's just a medical disease, all our chemoprophylaxis and all will work. But I feel this chemoprophylaxis only will not possibly work. Why? Because, as I said, just improving the socio-economic status of the population will definitely get down your tuberculosis burden. And that has been, I mean, it's a documented thing. Even before the advent of the first anti-TB drug in the year 1944, streptomycin, many European countries were able to scale down their tuberculosis burden by just improving the living conditions and the economic and the social conditions of their population. So that means what? If we improve the socio-economic condition itself, our natural immunity itself takes care of the disease. That, I mean, they will be immune to getting the at least the tuberculosis disease, if not the infection. And the second one I just wanted to emphasize is, as Dr. Priya said, these two, one communicable disease and one non-communicable disease, is closely associated with tuberculosis. So controlling diabetes mellitus in the population, controlling HIV and giving them the highly active antiretroviral therapy will greatly improve their immunity and lessen the risk of getting the tuberculosis. And of course, I have seen as a clinician over these many years, about more than 3 decades, physical and mental stress greatly predispose a person to contracting the tuberculosis disease. So that is how we are seeing many of these information technology, IT sector people, even young people, 25 years, 30 years, breaking down with tuberculosis because of their possibly the work stress and inadequate sleep and taking junk foods, all those things. So reducing the physical and the mental stress also will go a long way in preventing the disease. And of course, as Dr. Priya said, mask. I have seen my personal experience in our institute as well as my personal practice, as well as it is vouched by the state TB department. The tuberculosis new cases have come down over these 2 years, possibly because people are wearing masks because of COVID, thanks to COVID, and the because those who cough at least. We were teaching the patients about this cough etiquette, but now wearing mask I think has greatly reduced the new cases. That is what we have seen over these 2 years. But they say it's still too early to conclude that part that it is really coming down. So we'll have to wait for maybe another 1 or 2 years. And the other thing, again, this is again a pet topic for me. I used to tell even when I was doing my post graduation in the year 1989 to 91, tuberculosis should be the program should be a vertical one. What do I mean by this? So it is now integrated with the general health services. There are no specific personnel for doing only the anti-TB job, because those who are in the tuberculosis prevention and the tuberculosis treatment part also, they do other jobs, like even in districts, even in Chennai, this urban primary health center doctors and all, they have other burden. They have to see the outpatient, they have to see antenatal cases, they have to do immunization, plus this tuberculosis program is there. So what we did for eradicating leprosy, it was a vertical program. A dedicated leprosy officer, district leprosy officer was there. Dedicated medical officers who were only doing anti-leprosy work, and the dedicated field workers were there. So I think the administrators who are involved in that, I think should think about this. And if we have to really eliminate this disease, I think it should only be a vertical program. Of course, the cost will be there, but if we see the cost, I don't think will be near to eliminating the disease. And regarding the drug-resistant tuberculosis, drug-resistant TB is man-made. Either it is made by the doctor by giving inadequate or improper regimen, or by the patient who defaults. So the diagnosis is always a laboratory diagnosis, and it should be properly monitored. If we are able to do a proper work by giving, say, proper treatment in the first place, we can as well prevent drug-resistant tuberculosis. That is about DRTB. And finally, this 3HP, as she said, the 3HP, since it's a weekly one, it's going to come almost everywhere. Now we only follow the 6H regimen, but this 3HP is going to replace 6H soon everywhere. But we should be very careful in, say, giving. It should be only a supervised, directly given treatment. So then only it will work. Otherwise, if we just ask the patient to take once weekly for 12 weeks, they're going to default or miss out the some of the doses, and it's not going to work at all. So this is about my observation, and thanks again, VC Madam, for giving me this opportunity.
Thank you, sir. It was a nice revelation that actually even mental stress can cause this tuberculosis, which is quite scary actually. But now over to Dr. Uma ma'am in case she wants to add in something. Uma madam.
Yes, ma'am. Hello.
Yes, ma'am.
Yeah, thanks, ma'am. Thank you for considering me as a chairperson and also for Priya, ma'am, for suggesting me. So my point was nothing. It was an excellent presentation. And one thing I want to suggest is all in the paper. Whatever we said, diabetic patient has to be screened for TB. It's not happening in the field. It's everyone, the healthcare personal's duty to follow the guidelines. And if we start screening on
Yeah,
what?
that's exactly what Dr. Vijay Chandran was saying, that it has to be a dedicated person doing the job.
Yeah,
Otherwise,
that only. Otherwise, we are not going to eliminate TB. That's my point. Because we are saying we have to eliminate, but we are not practicing. That's happening. Even HIV, we are screening. We are that's happening for since it's a long ago disease, and we were afraid of the disease. Now we have started screening for opportunistic, but it's not happening in diabetes. That's it's very it's everyone's responsibility. It is not the individual who is working in the tuberculosis. It's everyone's responsibility to stress on the importance of screening and also to prevent tuberculosis. And thank you, ma'am.
yes, ma'am, I hope it reaches far and wide. Just about two questions, ma'am. Every time
Yeah.
you subject the screening of the blood to the back test and then do the drug sensitivity before you start the drugs, or how does it go? Priya, ma'am? Mute, madam. Please unmute yourself, ma'am. No. Unmute yourself, ma'am.
Yes, ma'am.
Yes,
Ma'am,
ma'am.
actually, that is what is suggested, but it is happening, but it is not happening in all the sites, madam. Because if you look at testing, it is not available in all the areas. So the program NTEP, though clearly says that, said that there is, as Uma said, as Uma madam said, there is a gap between what we, the program says and how it is implemented practically.
So it's only an empirical starting of it, huh?
No, it is, there's drug sensitivity is done, but eventually, if the patient continues to stay positive, it will definitely be done. But as the program says, for all patients, in reality, it doesn't happen. Vijay Chandran sir can give me more practical things, because this is what I observe in the field practice, in our field practice area. I am telling you, but sir will be able to tell us better, because he must be having a much better overview.
CBNAT is mandatory, madam. Even before starting treatment, CBNAT as per the program, but it is happening here in Chennai. But I am not sure about other places, but definitely it is happening everywhere in Chennai. CBNAT is mandatory. We have to rule out MDR, because CBNAT will tell whether MTB is detected or not, and whether that specimen is resistant to rifampicin or not.
Sir, but my humble submission is, it is happening only in Chennai, sir. And again, there is it is not uniform. And if we look at the primary health centers, there we don't see the CBNAT happening. But of course, if the patient is continuing to be positive, then they manage to do it. But otherwise, at the time of initiation, we don't have the reports to start the therapy.
No, but Dr. Priya, this is mandatory. As per the program, it is
That is what
mandatory.
I'm saying, that there is a gap between.
No, but no. I feel in Chennai, at least in government sector, it is there. It is being done. But again, as you say, in private sector, not all doctors do this CBNAT.
Even in government sector, in the primary health centers, not all patients have it. It is done. That's what I said. If the patient is not responding after the end of
I'm not aware of that, but in Chennai, it is happening. As far as I know, Chennai is definitely happening in the government sector, but not in the private sector. Not always in the private sector.
Yeah, true.
Sir, what would be the incidence of tuberculosis bovis and the diagnosis part of it in humans?
No, it is very less, because bovis is because of this pasteurization of the milk. Bovis to a great extent, almost it is not there, we would say. It is almost not there because of the pasteurization of milk. Then again, Indian way of boiling the milk before taking. We don't take raw milk. So boiling definitely kills all the bacteria, and because of the pasteurization, bovis is almost eradicated.
Okay, so sorry for my ignorance, but what happens to a person who is in contact with tuberculous bovis animal? I mean, a cow with the tuberculous bovis, does the contact person get it?
Yeah, theoretically he can get it, but the only thing is in animals, I don't think many people are aware. In animals, they don't treat the animal with the tuberculosis. They kill the animal immediately after the diagnosis. So that is how they deal with the tuberculosis in animals. It might be inhuman, but for animals, they don't treat it. They kill immediately. So the chances of transmitting is very less. Of course, as you say, theoretically it might be possible, but bovis we don't see at all almost because again for these two reasons. One is pasteurization of milk. Second one is the moment the animal is diagnosed with the tuberculosis, it's been laid down.
Oh, okay. Thank you. If there's any more question from the audience, anyone would like to add in or ask? If none, it was wonderful interacting with the three of you. Thank you, Priya ma'am. Thank you, sir. And thank you, ma'am, for the really wonderful session. And we both enjoyed it thoroughly. Thanks a lot once again. Maybe we'll meet in the third week with some other speaker. Thanks a lot, ma'am.
Thank you, madam.
Thank you, ma'am.
Thank you, ma'am.